This talk is made up of two distinct and essentially unrelated parts, CT perfusion and MR diffusion, although they both share one important This talk is made up of two distinct and essentially unrelated parts, CT perfusion and MR diffusion, although they both share one important feature, namely that they are used by many of us as black boxes. We have some patterns and rules that we've learnt and we apply them, perhaps hesitantly, but most of the time it works fine. We also have vague memories of what perhaps is going on inside, but other than some platitudes about how blood flows through the brain or how easily water molecules move around, we couldn't really explain either phenomenon. And that's fine. After all, most of us don't really understand how an MRI scanner works, but it doesn't stop us putting it to good use. So this talk is not about teaching you something critical to routine everyday work. Instead, what I hope to do is take a short detour and scratch the surface of perfusion and diffusion. Both are important and powerful, and having slightly better understanding of what's happening under the hood can get you out of trouble when things don't go according to plan. It is also, for lack of a better word, interesting, and I believe it behooves us to have a better understanding of the tools we use. Many radiologists, trainees, radiographers and clinicians alike find perfusion daunting. For one thing, they are brightly coloured, which as we all know freaks most radiologists out. To make matters worse, they all represent an Augean stable of acronyms, CBV, CBF, MTT, TMAX, etc. The result is that often they are ignored or reported vaguely as a mere afterthought. Often they are reported incorrectly or automated maps are relied upon too heavily. That's a shame because in a number of situations, they do have tremendous power. Let's take a moment and understand what we are actually doing when we're obtaining perfusion. I should note at this point that CT perfusion is very similar in many respects to MRI dynamic susceptibility contrast or DSC perfusion, and that the concepts are largely transferable. There are many differences, of course, but largely, instead of relying on iodinated contrast increasing tissue attenuation and vessel attenuation, MRI relies on gadolinium-containing contrast agents, decreasing T2 star signal. Due to all the problems with access in the emergency setting, MR perfusion is not as frequently used as CT perfusion in the setting of acute stroke, but it is of course hugely important in the assessment of primary brain tumours and many other conditions. Anyway, let's take a big breath and here we go. We begin by injecting contrast into the arm usually as a tight bolus, and by that I mean the injection is performed at high rates so that all the contrast enters the circulation in only a few seconds. By the time it's worked its way up the arm, through the right side of the heart, through the lung and back to the heart and finally up to the brain, it has been diluted somewhat by non-contrast containing blood from elsewhere in the body and has spread out. Therefore, when we examine the concentration time curve of the terminal internal carotid or basilar artery, we get a slightly broadened curve, and this is essentially what the tissue will receive. We call this curve the arterial input function, or AIF. And having a normal curve is essential if the rest of the perfusion study is to be adequate. Anything that impairs this process, such as occlusions, collaterals, shunts, etc., will potentially make the examination uninterpretable. A similar process occurs within the brain's microcirculation. The number and size of these small vessels affects the speed at which contrast traverses the capillary bed and how much of it remains within them. This in turn changes the shape of the bolus that we see both within the tissue, which we call the tissue concentration curve, as well as eventually on the venous end, for example the superior sagittal sinus, and we call this the venous output function or VOF. What we can't directly observe is the effect of the microcirculation on the arterial input function. This is what results in the change of shape from arterial input function to the observed tissue concentration curve. It is this microcirculation effect that will vary from region to region and gives us an insight into what is happening at a local level. We call this effect the residual tissue function. Although we can't directly measure it, since we can measure the tissue concentration curve of the tissue as well as the arterial input function, we can calculate the residual tissue function by a process called deconvolution. If you've not studied a great deal of mathematics, you may not have come across the term convolution. What does it mean? Well, convolution is a mathematical operation on two functions that produces a third function. In other words, how does the shape of one be modified by the other? The the process can be reversed, and this we call deconvolution. And the details of this are entirely tangential to what we need to know, but as always, having more context is better than not having it. Anyway, we now have 3 curves. 2 of them are measured and 1 is calculated, and from these curves we can derive all the other parameters. Directly from the residual tissue function, we can obtain cerebral blood flow and Tmax. Cerebral blood flow is simply the maximal height of the residual tissue function, and Tmax is the time from the arterial input function to the maximum value of the residual tissue function. You may encounter time to peak, which is obtained by looking directly at the tissue concentration curve, but more importantly, we can calculate cerebral blood volume by dividing the area under the curve of the tissue concentration curve by the area under the curve of the arterial input function. And now that we have cerebral blood volume and cerebral blood flow, we can calculate mean transit time by dividing CBV by CBF. Do you need to know this, how to report perfusion studies? Well, no, not really. But it does come in handy to troubleshoot, and I'll show you a case later where this is important. In any case, the values we obtain for each of these at a voxel by voxel level can be displayed using some kind of heat map to give a visual representation of how they vary from region to region. These look like blurry anatomical images, but they're really not. They are spatial representations, and that's why we sometimes use the word map to show you how the values of certain calculated parameters vary from region to region, and importantly, over time. You can argue correctly that this is essentially true of all CT and MRI. It's nonetheless worth remembering that these images are a number of steps away from merely looking at the shape of the brain, and at each step, there's the opportunity to introduce artifact and errors. Okay, we've made it. So now let's look at 2 cases, both from patients who were brought to the emergency department and received stroke protocol CT studies with perfusion to assess for the presence of an acute infarct. Here in this first case, we can see that both Tmax and MTT look essentially normal. What's worth noting is that the heat maps that we use for both of these are skewed towards demonstrating prolongation, because after all, that's the thing we're mostly interested in, especially in the setting of stroke. When we look here on the right, particularly on Tmax, we can see that there's actually a great deal of dark blue, indicating that not only isn't there prolongation, but there's shortening. And when we look at both CBF and CBV, we can see that both these territories have markedly increased perfusion. As I've mentioned before, the important thing about perfusion is to try and separate mentally between surface cortical vessels and underlying parenchyma. In this instance, obviously the overlying cortical vessels are markedly enlarged, but so is the degree of perfusion of the underlying white matter. When reviewing CT and CTA, we don't see any evidence of a stroke, but we do see, perhaps with the eye of faith, that the sulci here on the right are slightly more compressed than those on the left. And indeed on CT angiography, we can see that there is prominence of the surface cortical vessels. And this patient had actually had a seizure immediately before the scan. And what this represents is ictal or immediate post-ictal hyperperfusion. Moving on to case 2, and this is one of my favorite cases. And I've seen this twice now just at our institution, so presumably it happens not infrequently. This patient presented with stroke-like symptoms, had a CT brain, and then had perfusion, and then had CT angiography. And these were the perfusion maps. When we look at mean transit time, it appears that a large part of the brain has quite prolonged transit. And similarly on Tmax, particularly here on the left, in the middle cerebral artery territory, and perhaps in both anterior cerebral artery territories, there are areas of really quite marked prolongation, whereas the posterior fossa appears normal. Looking at CBV and CBF, the right middle cerebral artery territory looks about right. The right anterior cerebral artery territory and left anterior cerebral artery territory and middle cerebral artery territory appear reduced, both in terms of cortical vessels and parenchyma. And CBV similarly has reduced values. Whereas in the posterior cerebral artery territory and cerebellar hemisphere, we see markedly elevated artifact. So a quick scroll through the non-contrast confirms that there's no real abnormality on either side or in the posterior fossa. And CT angiography is equally unremarkable. We have imaging from the arch up to the internal carotid arteries, and there's no occlusion, and there's no abnormality to account for that elevated cerebral blood volume and flow in the posterior fossa, and nothing to account for reduction in anterior cerebral and middle cerebral artery on the left. We've already had a look at the individual perfusion maps, which were confusing, so instead let's have a look at the automated maps and see if this helps. And if you just believe these maps, then this is great. It does confirm that there's right-sided penumbra, and we did see prolongation of MTT in that area, and only a small core perhaps in the posterior MCA territory here on the left. This even gives you the illusion of accuracy by giving you particular values down to 1 decimal place. Let's not forget, however, that these perfusion maps are generated by a number of calculations which include the arterial input function as the starting point. So let's have a look at that. And we can see here that the arterial input function in this instance has been set to be the basilar artery. But something odd is going on with these early images because we can already see very hyperdense material in that posterior circulation on the left and cerebellum. And this is where one of the sequences that is often not looked at but can be tremendously helpful really comes into play, and that is the diffusion source data. If we have a look at this one starting from time 0 and moving through time at this one location, we can see that very early on we have extremely bright contrast posteriorly, which then fades away. And what this represents is arterial cannulation during the perfusion phase. And what happened was the patient was cannulated, had their perfusion imaging, and reported a lot of pain during that injection. So after the perfusion, the technician replaced the cannula with a new cannula, not recognizing that it was an arterial puncture, and went on to perform a normal CT angiogram. But how does that arterial cannulation lead to this? Well, if we go back to the CT angiogram and scroll down, we can work out the anatomy quite easily. This patient had a right antecubital fossa arterial cannulation, and the injection is at such a high rate that it not only competes with antegrade flow through the axillary and brachial artery, but actually is sufficient to reverse that flow. And so contrast comes up through the axillary artery into the subclavian artery to the origin of the right vertebral artery, and then passes antegradely up the vertebral artery into the basilar circulation, which is what we used to determine the arterial input function and therefore occurred way too early, and then up to the basilar, where it supplies the posterior cerebral on the left, but note that there's a fetal right posterior cerebral artery accounting for why on the right the PCA territory is spared. So this is an example of understanding that many of the maps are calculated by using the arterial input function. Means that there's an opportunity here for artifact. In this instance, the arterial input function was from antegrade flow of undiluted contrast injected retrogradely through the brachial artery. And having a sense of these potential traps means that you can identify this when it occurs. And before we finish, let's have one other case where we can see some of the pitfalls of relying too heavily on automated perfusion interpretation. In this instance, we have a calcific embolus here in the middle cerebral artery branch on the right in the Sylvian fissure. And on more superior branches, we can already see faint loss of grey-white matter differentiation. Clearly, you would review this on stroke window in practice because it would make this stand out a great deal more. When we move on to look at the perfusion maps, it gets a little bit more complicated because we're expecting to see a sizable middle cerebral artery territory region of prolongation of both mean transit time and Tmax, but we're not seeing that. Instead, we're seeing maybe some prolongation here anteriorly, but that doesn't make sense with MTT. And in this instance, also CBF and CBV are elevated, a little bit like the previous case. And the temptation is, when things get complicated on these normal maps, is to rely instead on the automated maps. And when we look at this, it seems to make you feel much better, because in the area that there was a calcific embolus, we see an area of penumbra with no matching core, and maybe some other areas in the frontal lobes. Again, we're given these values that give you the impression or illusion of accuracy. But if we go back to these maps, none of this really hangs together. First of all, these areas are way too inferior and don't match the territory at all. And additionally, we have these crescents posteriorly of abnormal perfusion, very elevated CBF, but also very prolonged Tmax. And once more, this is where looking at the perfusion data is really helpful, because as we scroll through the perfusion of this particular patient, we can see that they move their head from side to side during the perfusion scan. This is at one level, and this is at another level. And because these maps are looking at values and how they change over time, any movement during the scan can cause tremendous impact and artifact on the final maps generated. MRI diffusion-weighted imaging was a game changer in ischemic stroke. For the first time, and this was in the early 1990s, before my time I should add, we were able to visualize ischemic tissue within minutes of onset, rather than having to wait for it to become evident on CT, or for that matter MRI, other sequences such as FLAIR or T2. Because this was first successfully applied to stroke, to this day DWI is most closely linked in our minds to this clinical setting, and the way of describing diffusion remains binary. In other words, we say there is or there isn't diffusion restriction. I recognize that this is a hobby horse of mine, and I have touched upon this in other talks. And this is probably not the time or place to revisit this particular topic in any depth, except to say that understanding how diffusion works at a histological and pathophysiological level can give you valuable insights, not just into stroke, but also many other areas of neuroimaging. Before getting into the details of how DWI, unlike CT, manages to show areas of infarction so quickly, I want to take a detour and discuss the term cytotoxic edema. We're all taught that cytotoxic edema represents cellular swelling due to movement of water from the extracellular space to the intracellular space. And we contrast this to vasogenic edema, which is increased extracellular fluid as we encounter surrounding an abscess or in a tumor that has disrupted blood-brain barrier. Cytotoxic edema we use to describe the mechanism by which both DWI changes and established CT changes become apparent. When you think about it, it's a bit odd, given that DWI will become strikingly positive within minutes of ischemic onset, whereas CT can take up to 24 hours or more to become well demarcated. The reason is that we use the term cytotoxic edema far too loosely. And in fact, I believe we probably shouldn't be using it at all, especially in the context of CT. Now, I doubt that in one talk I'm going to change that, but I do think that it's helpful to understand exactly what is going on. And at the end of this side quest, I hope you'll have a better understanding of both CT and MR. So let's start by setting up a thought experiment. We're going to magically teleport a cube of brain tissue out of someone's head and into a sealed box. This tissue is now profoundly ischemic, neither receiving nor draining out any blood. And we can now image this cube with both CT and MR over time, let's say the first 48 hours. Now ask yourself the following three questions. Would it change in volume or swell? Would it change in CT density? And would it demonstrate diffusion restriction? If you're not immediately sure how you're going to answer these three, go ahead and pause the video to consider this for a second. Let's tackle these in order. The only reason you may have said that yes, it would increase in volume is if you're thinking about what happens to ischemic brain in vivo. But it won't take you long to realize that there's really no way that this cube of tissue can change in volume. After all, for tissue that is mostly comprised of water and therefore incompressible, to change volume you need to add or remove mass. And this is clearly impossible in our sealed box example. So that leads us to question 2. Would this cube of tissue change in CT density? Well, again, we need to stop and think briefly about what density on CT represents. CT density is determined by how much of the incident X-ray beam is absorbed or scattered, such that it doesn't reach the detector on the other side. If none of the beam is blocked, then we get a value of negative 1,000 Hounsfield units. The more of that beam is blocked, the higher the Hounsfield unit is, and we calculate how much each voxel contributes to the overall attenuation, with water being given a value of 0 Hounsfield units. How much X-rays are absorbed or scattered, and therefore the density of tissue on CT, is almost entirely determined by the atomic composition of tissue through 2 processes, Compton scattering and the photoelectric effect. Importantly, the molecular arrangement of those atoms, and certainly not the cellular makeup, does not contribute to this. In other words, if you start with a voxel of tissue that has a certain number of atoms of carbon, hydrogen, and oxygen, then it will pretty much determine the absorption characteristics of that tissue, and it really doesn't matter if those atoms are arranged, whether they're intracellular or extracellular, or whether there's a water molecule that has shifted from one space to another. So shift of water from the extracellular space to the intracellular compartment won't change anything. And this is why CT in vivo in the acute setting is rubbish. Even though we'll see in a minute that cytotoxic edema starts to develop within minutes of ischemia, CT won't show any changes in the parenchyma for hours of these changes, and these are not due to cytotoxic edema. At least not directly. In our example, where there's no change in atomic composition of the cube, there is no scope for meaningful change in CT density, and no matter how long you scan, the density will roughly stay the same. Eventually, I suppose, the tissue will turn into mush and separate out into layers as if it had been centrifuged, but that will take much more time than we have available to us today. And lastly, will this teleported cube of tissue show diffusion restriction? Yes, pretty much immediately, because unlike CT changes, it does actually represent local redistribution of water. So let's dive into this a bit deeper and see how this early true cytotoxic edema occurs and how it sets the stage for later CT changes. Cells are little semi-permeable bags of water and a whole bunch of organelles and protein and enzymes and solutes. They're separated from each other by extracellular space that also contains water, solutes, and many other structures. In practice, the extracellular space is far smaller than the intracellular space, only accounting for approximately 20% of total brain volume, although exactly how much is not easy to measure in vivo, and additionally depends on the region of the brain you're looking at. For now, let's forget that and just look at a single stylized cell with water on the inside and water on the outside. This could be a neuron or an astrocyte or an oligodendrocyte, it really doesn't matter. All of these cells have a problem, and that problem is that they have a great deal of stuff on the inside that results in brisk osmotic gradient. The solution that many cells throughout the body employ is an ATP-dependent sodium-potassium pump. This pump uses a molecule of ATP for power and expels 3 intracellular sodium atoms in exchange for only 2 potassium atoms. This not only results in a net reduction in osmotically active elements within the cell, but also creates a membrane potential with more positive charges on the outside. These electrochemical gradients can then be used to power all sorts of other transmembrane channels, including neuronal discharge. The problem is that these sodium-potassium pumps are energetically expensive. Estimates vary widely, but as a ballpark, the brain, that accounts for only 2% of the body's mass, but uses around 20% of the total resting energy production, and about half of that energy is used to run that one pump. In other words, 10% of your total resting metabolic rate is used to kick sodium out of your brain cells. You'll also recall that the brain doesn't store energy locally. It doesn't have glycogen or fat to turn to if blood supply ceases. It obviously also doesn't store oxygen locally. Thus, very, very quickly after blood flow ceases, these cells run out of ATP and these sodium-potassium pumps grind to a halt. And this is where a cascade of events takes place that results not only in cell swelling, but neuronal dysfunction and eventual irreversible cell damage. Sodium stops being expelled and gradually accumulates within the cell, drawing with it chloride ions. The combination contributes to an increased osmotic gradient, which in turn results in water from the extracellular space passing into the cell and resulting in cell swelling, while simultaneously shrinking the extracellular space. So instead of thinking about the inside of the cell, let's focus on the changes in the extracellular space. It's now depleted of sodium, chloride, and water, and this is what we'll see is the eventual cause of brain swelling. As an aside, it's also worth noting that in addition to these changes, there's also an increase in extracellular glutamate, which in turn results in calcium entering cells, and it is this calcium influx that eventually leads to an irreversible cascade of intracellular events that will end up with the cell dying. That, however, is a topic for another day. So to recap, where do we find ourselves at this stage, a few minutes after the onset of ischemia? Well, there's been a shift of water from the extracellular space to the intracellular space. This is cytotoxic edema. It has occurred quickly and represents merely a local shift of water from one space to another, so that now we have swollen cells and volume-depleted extracellular space. It's important to note that this is a local effect occurring at a microscopic level, much smaller than a voxel. But it is this process that we image so readily with DWI. Without going into any of the details of how diffusion-weighted imaging works specifically, I've covered that elsewhere, DWI assesses the ease with which water molecules can diffuse through tissue. The more easily and thus further they can move in any given time, the more facilitated the diffusion is said to be. Thus, in ventricles where only other water molecules get in the way, diffusion is very facilitated or unrestricted. ADC values will be around 3,200 times 10 to the minus 6 millimeters squared per second. When instead water molecules keep running into cells and organelles and membranes and extracellular matrix structures and they don't get very far, this is normal and represents normal diffusion restriction within the brain, with white matter having ADC values of about 750. A fact that I go to great pains to make my trainees understand with, I must admit, limited success, but undeterred I'm going to give it another go here, is that normal brain diffusion restricts a lot. That's why it's fairly dark on ADC and not bright white. Both the words restricted and facilitated are mostly relative words, and they're begging for comparison to something. When we talk about normal brain, this makes sense. We know how much normal brain should restrict, and deviation from this expected normal value can be said to be restricted or facilitated. So in the setting of acute stroke, we say there is diffusion restriction. We are actually saying the affected part of the brain restricts the diffusion of water molecules more than normal brain should. Whereas in encephalomalacia or gliosis or in some other setting of edema, the signal is high on diffusion-weighted imaging and has higher values on ADC. We use the term T2 shine through to mean, I know this appears bright on DWI, but actually this part of the brain does not restrict the motion of water more than it should. In fact, it allows water molecules to move around more easily. That's what facilitated means, and so it doesn't represent an acute stroke. Recognizing that we are using the terms restricted and facilitated as shorthand is important. It's also important to realize that they don't make a lot of sense in other settings, such as tumors. Unless it's clear that we are comparing it to some known value, or unless we use the word restricted merely to mean low ADC values and facilitated to mean high ADC values, then this introduces confusion and vagueness in both the reporting radiologist's mind and the reading clinician, and I think it's generally best avoided. Rather, we should be talking about ADC values either in quantifiable terms, such as 1,200 times 10 to the minus 6 millimeters squared per second, or relative terms, such as similar to white matter. Anyway, getting back to stroke. Within minutes of ischemia, the extracellular space is volume depleted, and therefore the water molecules that are left in that space are surrounded even more than usual by tortuous structures that impede their movement, and ADC values in the extracellular space go down. There is greater than normal diffusion restriction. There are many additional interactions that lead to changes in ADC values, but this gives you a reasonable intuition about what's going on. You may be wondering, hang on, sure, the extracellular space is now more diffusion restricting than before, but shouldn't the intracellular compartment be expanded and allow easier diffusion? And if you're wondering that's a good question. And you'll be right. Intracellular ADC values do actually go up. But for reasons that I'm not going to go into, and which frankly I don't fully or even honestly partially understand, even though the extracellular space is only 20% of the total volume, it is the dominant contributor to changes we see on diffusion-weighted imaging, and thus the overall ADC values of tissue reflect the status of the extracellular compartment. Great, so now we understand why DWI becomes abnormal so quickly, and we understand why CT does not change acutely, but we still have to address why CT eventually demonstrates low attenuation and swelling. The phenomenon that leads to CT abnormality is a separate process known as ionic edema that occurs as the result of cytotoxic edema. Remember that due to the failure of the ATP-dependent sodium-potassium transporter, the extracellular space was depleted of water and sodium that flooded into the intracellular space. This leaves the extracellular space not only narrowed, resulting in increased diffusion restriction, but also hyperosmolar relative to the adjacent blood vessels and adjacent extracellular spaces from adjacent tissues. Ionic edema represents the replenishment of depleted extracellular space by water and sodium from adjacent structures, primarily perfused capillaries. This adds water, and it is this additional water that causes brain swelling and lower attenuation on CT. It is worth noting that for this to occur, a source of additional fluid must be present and therefore requires some blood flow. In the setting of ischemic stroke, this will be either the normal primary vessel if it's recanalized, either spontaneously or due to therapy, or via collaterals. In fact, the center of an infarct that is not reperfused will not swell as much as the periphery because of this. In cases where reperfusion is achieved but an infarct is not prevented, swelling is maximal because there's a ready supply of blood to drive ionic edema. On top of this, there will be also endothelial damage and breakdown of blood-brain barrier, adding vasogenic edema to the swelling. This breakdown will also allow the passage of contrast out of the vasculature and will eventually allow subacute infarcts to enhance. So where does this leave us? Well, the main idea I would like you to take away from this talk is that there's a real benefit to taking the time and scratching the surface of the tools that you use in everyday practice. The more you can relate your practical day-to-day radiology to underlying pathophysiology, the more everything will satisfyingly fit together. That's not to say that you reach a level of understanding that is complete. Far from it, I suppose. Each layer poses its own questions, and unfortunately the further down you go, the more technical and esoteric are the explanations. Nonetheless, I firmly think we owe it to ourselves to try and practice radiology as a cohesive scientific whole, rather than merely a set of artisanal heuristics. And I encourage you to take the time to dive deeper in all these topics. Thank you.